Now I'm going to move into open injuries. In an open injury, open soft tissue injury, the skin is broken. And the key thing here, I think this is the big key, is that the protective function of the skin is lost. And that's really the big difference. It does lead to external bleeding, although remember, this is not really different other than we can actually see the blood coming out. With the closed injuries, we still had bleeding, it just wasn't coming out. And then infection is a huge risk with open soft tissue injuries. Infection becomes a huge issue. Here's a list of your open injury types. We have abrasions, lacerations, punctures, avulsions, bites, and amputations. So here's some abrasions. I think everybody has probably had one of these. Growing up, I think all of us probably skinned our knees at some point. That's an abrasion. This is where you lose portions of the epidermis and the upper dermis by a rubbing or scraping force. It's usually associated with capillary oozing or leaking of fluid. So think road rash. You got your motorcycle guy who's out there and he lays down his bike and he ends up with a terrible road rash. This is a laceration. It's a cut by a sharp object or blunt trauma. It's typically longer than it is deep. And it's fairly straight. Like you can see, this is a fairly straight line. It's not like, star-shaped where there's, 3 different cuts or anything. It's a pretty good line. This may be associated with severe blood loss and damage to the underlying tissues. It just depends on how deep it goes and what it actually cuts. It can be linear. So the types, it can be linear or it can be star-shaped. But again, even this, it's not, it's still straight lines. I guess what I was trying to explain up here earlier is it's not like you have a flap of skin like that. That is actually a different term that we're going to come to. So you can have, basically, as long as they're straight lines, they can have kind of a star shape to them. A puncture. A puncture results from a stabbing force. In this case, the wound is deeper than it is long. The problem for us is that it's very difficult to assess the injury extent. You may still have an object sticking out, so whatever caused the puncture may remain impaled in the wound. An avulsion, and this is kind of what I was referring to earlier. If you have a really irregular flap of skin, for example, then it's called an avulsion. But this is basically where you have a piece of skin that's torn loose as a flap or completely torn from the body. It tends to result from accidents with machinery, motor vehicles, clumsiness, around, whatever, tripping, falling. And what you want to do to manage this is replace the flap into normal position before you bandage it. Treat the completely avulsed tissue like an amputated part. So basically, if this piece here came completely off, you want to take it with you because a lot of times the docs can sew it back on and it'll help with healing. A bite is similar to a puncture. It can be an animal bite or a human bite. And the big key with a bite is the risk of infection. The nice thing about puncture bites is that we can usually gauge the depth. Not always. When somebody, let's see if I can explain this. So let's say we have this dog here, and this dog is angry, and he's got his fangs out. Oh, that's not very sharp. There we go. He's got his big angry fangs out. And he bites into you. He bites into somebody's hand, for example. So he bites into somebody's hand, and you find this puncture wound here. We know that basically the depth of the wound, it may be deeper than this tooth is long, but it's not so deep that we don't know. It can probably be 1.5 to 2 times as deep as this tooth is long, if that makes sense. Because when they bite down with force, and so they compress some of the tissues. But we can still gauge relatively how deep the bite is. With bites, one of the big concerns is the risk of infection. This is especially true with dog bites and cat bites. And there's one that's worse than the other, and for some reason I'm blanking on that. But there's a big risk of infection when you have animal bites in general. And so these are usually treated fairly heavily with antibiotics. Amputations. So you can see here this individual cut off the tips of 2 of the fingers there. So an amputation is the disruption of continuity of an extremity or other body part. The part should be wrapped in sterile gauze, placed in a plastic bag, and transported on top of a cold pack. Do not pack the part directly in ice, and don't let the part freeze because that damages the tissues. So how do we manage an open wound? We'll manage the ABCs first, which includes controlling the bleeding. Think of a tourniquet. Again, I'll abbreviate that TK. Think of a tourniquet. Is that going to be necessary to control the bleeding of the open wound? Prevent further contamination, but don't worry, for us anyway, we're not going to worry about trying to clean the wound. Our concerns are more with the ABCs. We want to immobilize the injured part, so splint it, and manage any hypoperfusion if it's present. If we have time to do wound care, we'll clean the area a little bit. I think one of the keys is maybe getting out any dirt or sand or rocks or debris that's in there. So we kind of rinse it out, place a bandage over it, and put a dressing on it. Generally speaking, it's a good idea to start with a sterile dressing, but admittedly what we do isn't really sterile. We carry basically prepackaged sterile 4x4s. They're a little bit more expensive than the non-sterile 4x4 gauze sheets. And a 4x4 is just a piece of gauze. It's 4 inches by 4 inches. So we call them 4x4s. There's also 3x3s and 2x2s, but you'll hear 4x4s. And that's all it is. It's a little piece of gauze, which is kind of a light fabric-y material that's really good at absorbing stuff, blood in this case. So we have some that are sterile. That means that they've been treated so all of the germs have been killed. And the non-sterile ones, which are still clean, they just haven't been specially treated to kill all the bacteria. Sterile dressings are going to be good when we have concerns, really major concerns for infection. So if you have bones sticking out, if you have a part completely amputated, when you have a really deep laceration, when you have a patient who's very sick. Non-sterile gauze, the Band-Aids that we get, like from the store, they're clean, but they're not necessarily sterile. And we still use those on our cuts and bruises and that sort of stuff at home. You guys have all probably, I say all, some of you have probably been in the kitchen, cut yourself, and you reached for a paper towel. Well, that paper towel is clean, but it's not sterile. So non-sterile when the risk of infection is low, when it's a small area, but the default really should be use a sterile dressing, use a sterile 4x4 in contact with the skin. We also have occlusive dressings and non-occlusive dressings, and it's probably easiest for me to show you in class. Suffice to say, an occlusive dressing is one that air can't flow through. So something like a piece of plastic wrap. We use Vaseline gauze. Those sorts of things are occlusive dressings. Non-occlusive dressings are basically anything that is not occlusive. You have wet dressings versus dry dressings, and there are also some complications with dressings. So there's some special considerations. If you have an impaled object, the way we're going to treat that is a little bit different. If you have an evisceration, which means this is when your guts are coming out. So this is when you maybe have somebody who's been stabbed in the abdomen, and you look down and you see intestines sticking out. And the key there is don't put them back in, and use big trauma pads. They're called multi-trauma dressings, and they're really big. You don't want to use small 4x4s because if they kind of get stuck under some of the intestines, it could be that you end up with a 4x4 back in that patient's abdomen when the surgeons go in to try and put the patient back together. Neck wounds are tricky because it's hard to put pressure on neck wounds, and gunshot wounds are also a little bit tricky. So for an impaled object, you can see you've got one here. Do not remove it. Stabilize it in place. The exception to this is going to be an object in the cheek, which you can remove, and then you want to dress the inside and the outside of the mouth. The concerns with an object in the cheek like this are the fact that it's probably sticking through, like you can see there's a pencil. It's sticking through on the inside, so you can see both the inside and the outside, so you know what's been stabbed and that sort of stuff. There are also airway concerns. If I've got something in a patient's mouth, I tend to want to remove it to make sure I can manage their airway. So the cheek is okay. It does have some vascularity to it. I think that's a word. It has a lot of blood vessels in it. So it may bleed, it may swell, but the good news is I can put pressure on both sides and control that bleeding very easily. Here's an evisceration. So the patient has a stab wound. You see the intestines coming out. So the internal organs are exposed through the wound. You want to cover the organs with a large moistened dressing, and hopefully this is with saline. Sterile saline. And then with either aluminum foil or a dry multi-trauma dressing. So this large moistened dressing should be a multi-trauma dressing. Cover it with foil or another dry multi-trauma dressing and secure it down. Don't ever use 4x4s and do not attempt to replace the organs because the doctors need to look at them to verify that they're not injured. An open chest wound. So you can see this guy has what looks to be a stab wound here. You want to, the concern is that it may prevent adequate ventilation. We can fix this by using an occlusive dressing. And you can see here it's a piece of plastic wrap. It's taped down on 3 sides, which is good because it basically allows the wound to breathe if it needs to. So if air needs to come out, it can, but air is not going to go in through this hole. So if the tension pneumothorax develops, lift the dressing corner to help relieve some of the pressure. And we'll talk more about what exactly is a tension pneumothorax in a different lecture. Neck wounds, like I mentioned, there's some concerns with neck wounds. There's a lot of vascular structures in the neck, so there's a risk of severe bleeding from large vessels. There's a risk of air entering to the vein and moving through the heart to the lungs. So you want to use an occlusive dressing here as well. Do not occlude the airway or blood flow to the brain. So you're going to put an occlusive dressing on. It would be a bad idea to take and wrap gauze all the way around a patient's neck. It's not a good thing to do. You have to be careful and suspect the presence of a spinal injury in the case of neck wounds as well. So gunshot wounds. Gunshot wounds are a special type of a puncture wound or penetrating trauma, which we also call it. So penetrating trauma. The transmitted energy can cause injury remote from the bullet track. And we'll talk about this more in a different lecture. It's called cavitation. You can look it up on YouTube if you want and find a video of what cavitation looks like. The other thing that can happen is that the bullets may change directions and they may tumble. So when they bump into like a bone, for example, there are a few things that can happen. It can either glance off the bone and just change direction. It can actually cause the bullet to tumble. So instead of having that, okay, so forgive my bad drawing. This is like my cartoon, bullet, what I thought bullets looked like growing up. So you've got the little bullet shape there. It could actually start to tumble, and that's going to change the damage pathway. It's not going to be a straight shot through. You can see here, this looks like a giant hole. As far as I'm aware, there's no, gun or anything that's going to produce something, or that has a bullet that size. The reason that you have a hole that size is either because of the cavitation of the bullet through the wound, or because the bullet decided to tumble through the area there. For us, it's impossible to assess the severity, and even in the emergency room, it's impossible to assess the severity of the injury. This patient has to go to the operating room. So that's it for this lecture. If you have any other questions, please be sure to bring them into class. Thank you.